Hello and welcome to this track. We're just grateful that you're here. This track is the TBI and behavioral health. This panel includes some really exciting people. First, I want to introduce you to Russia Nauer. Russia is the director of MindSource. You'll find out that I was excited when we're going to Colorado because Colorado is the leader in TBI intersection with the justice system and as a state. And we have a great honor to have Russia here to represent the state as well as her research and her interesting story becoming involved with the TBI system. Right after me, we'll be pleased to have Dr. Edie Zussman. Edie is a neurosurgeon, a researcher, and just so excited about her, in her world of discovery of trying to help individuals with housing and outreach. She discovered how vision and eye care and eye changes happen after brain injury. So a lot of parallel paths it's going to be exciting to explore together. So thank you for being with us. My name is Doug Major. I'll be presenting on to start off with the introduction of the visual behavior markers of the TBI to underserved populations and those relationships between substance abuse, PTSD, and justice involvement. My background includes years of a correctional hobby, started in 1983, did some research at the Youth Authority, we'll present later. Currently, I go to the San Luis Obispo County Jail every week or so, and every week go to a forensic hospital at California State Hospital for the criminally and mentally ill. So really involved right now, also involved with state facilities, federal facilities, and involved with being the co-chair of the COVD Juvenile Delinquency Committee many years ago. So let's start with silos. When I was a kid, teenager, I had a cousin that wanted me to go work at his feed mill, which I did for a whole summer. Shoveled out 8 dump truck loads out of these silos. Silos are interesting once you get in them. Very protective, you and the mice, but it is dangerous if you keep in those silos. And anybody who's been in the Midwest know that they can explode. And when we don't have proper rotation, this professional isolationism that we can have, it's dangerous. And so I want to use that as a metaphor. I'm hoping today that we break out of our silos and keep all of our fingers, because I'm just so excited. In fact, when Edie and Russia and I got together, we were so excited just to discover each other. So I'm hoping you get that excitement of discovery that we experienced. And of course, NORA is a place to build bridges and combine the efforts of all the different rehab individuals and use that powerful tool of vision to help those in our care. I have no disclaimers or disclosures, and so let's get right to the objectives. There's an introduction. We're going to talk about how post-traumatic neurological changes can alter behavioral outcomes and share some of the newer justice system research. I want to just give you a taste so that you can enjoy that yourself. It's so neat that there's a parallel system that's so excited about what we do. Why do specific individuals have much poorer health outcomes after a brain injury? We'll discuss a conceptual model that I feel comfortable with, how preexisting conditions can cause the dysregulation, including poor neural prediction, and how those can relate directly to mental illness outcomes. And the third thing is, are there programs available to help those who've had a post-TBI with behavioral changes? And so we'll be able to let Russia, and we'll start the introduction of the work behind the Colorado model we're so fortunate to have as a proof of concept, and provide connections for you so you can start applying this to your area and maybe do some pilots. So jail last month ago Friday, had a young woman come in, beautiful young woman, 23. She's there. When I asked about a brain injury, she had just had mild reading glasses. She just knew something was wrong, but she denied any brain injury. Well, I tried to have her across her eyes, and as you all well aware, painful convergence out at 12:13. I said, you've had a brain injury. She finally admitted that her boyfriend had thrown her into a brick wall about 18 months before. She sort of normalized this, and and again, she's in there for really self-medicating, and that's why she's there. And this is so common, particularly for women, that they intimate trauma, and then this sort of a lag of time, and then they enter the justice system, and we punish them. We all know about this. Phineas Gage, the classic Neurology 101, after hitting a tamping rod of doing railroad work, goes through his brain. This church-going sort of stable guy becomes erratic, goes across the world, and became really a poster child for brain injury. So we all know about this. Maybe you don't know about Cesare Lombroso. He'd take the newly killed from gallows, like the old anatomist used to before refrigeration, and discovered, hey, this serial killer had a smaller cerebellum. There was a neuro difference in this. So this is not new. It needs just application. Father of behavioral optometry made this quote: a child who is bright and clever at everything, yet unable to excel in school because of a visual defect, becomes more apt at crime. Optometry could contribute to the solution of the problem of juvenile delinquency. This was actually in a call from President, one of the presidents, and later President Truman. And there is a whole group that was involved with this for many years, and that included me. I won't go in depth. At the time, we were really looking at increasing literacy, but in our little study, well, we had 2,000 screened, single blind controlled, found that we could really increase the individual's reading score based on eye movements. But the thing for maybe more on point is the on-site behavior improved dramatically after our treatment, after brain treatment. And one example, a treatment group had 74 fewer level A, control group had 226 more level A behavioral infractions. Changing vision and vision care, brain training does make a difference. Let's go ahead and bring up really one of the key researchers in Colorado, Kim Gorgan, who works over here at the university. Great on-site. We'll give more information about her later.
And this thinking about brain injury, sequela, the consequences of brain injury as the physiology of a behavioral health complaint, it really goes a long way towards destigmatizing that presentation. It no longer becomes about personal failing or a moral failing. This is just the physiological outcome of an injury. So the numbers of people who complain of mental illness / affective distress after brain injury are staggering. So almost half of people who have no pre-injury history of mental health complaint will develop clinically significant mental health presentation within that first year of their injury. So,
and isn't that amazing that this mental health fallout, we follow up. Now, there's all different different studies use different criteria for mental health. They're not as specific as we do in optometry, but isn't it fascinating? And I love this, that these individuals who've had no previous injury, they don't know really where to go, and it's confusing to them. We have that confused look. They don't know there's something wrong, but they feel bad, but they don't know. Because they've never been in a mental health situation before. And this idea of that they experienced emotional problems between 6 months and a year post-injury, there's sort of this delay, like I described in my idealized case. And of course, this affects suicide and family life. And this is not anything new. And those who are involved with the legal system, look how many have a substance abuse diagnosis, as well as mental health challenges, exposure to childhood violence. All those things are just so important to address. So what types of TBIs are reported? We're going to just do a cross-section of different states. Here's in Michigan, DV is domestic violence. For women, domestic violence is the most common cause of TBI damage, and isn't that tragic? When we talk about the justice system interaction, history of Substance abuse, history of mental illness, suicide, childhood trauma. These are all interrelated traumatic events that cause, and they associative or causal. And then, of course, the brain injury outcomes are dose dependent. So with each injury, there's more possibility and probability of more depression, more anxiety, cognitive problems, and that's out of Kentucky. Lots of great information, research. This is just a touch of what I can show you. And so, why is this important? Because as a healthcare provider, we're all on the front lines of behavioral care. We must be aware. We must be aware of those who, majority of those who are homeless have a brain injury along with their mental illness, substance abuse, all mental illness, and then of course justice involved, which we've been involved with, and these things are all interrelated. I see the justice system walk out with their black bag to go back into their homeless shelter. Again, surrounded by substance abuse with the mental illness, all those simultaneously. And how does this react? I thought this clip was really great to describe the effect on behavior, and who better than race car driver Dale Earnhardt.
I couldn't bite my tongue. Like, my attitude and my emotions and shit was out of whack. Like, I couldn't control my anger, and I was like, anybody say something I didn't like, I'm like, well, I wanted to tell them to fuck off,
Right.
And that was just not like me. I couldn't like keep myself calm, and everything that I heard like made me angry. It was the craziest thing. Even people just talking about stuff would just get under my skin. I'm like, real impatient.
You can sort of see how that would cause some problems and he did a great job describing that. So here's the question: why do some individuals transition from like a social drinking into alcoholism, or gambling into addictive behavior, from running those behavioral yellow lights and the red lights? And a lot of research on how the stages of addiction goes from different uses. And again, when we talk about TBI, this really helps this connection, and particularly those who know Mickey Collins, the first concussion center up in Pittsburgh, he used this great comment.
But there's really no, like, you hit your head this way, you have this problem. Rather, Peter, and this is important, concussion fights dirty. Like, whatever you bring to the table that's weak seems to be affected more generally in patients. In other words, there's pre-existing risk factors to have a worse outcome from this injury that will probably be quite surprising to hear for people. And not only those risk factors not only put you at more risk for less force causing concussion, but they tell you what kind of concussion you're likely to have if you do have a concussion. For example, we talked about the different types of concussions. If you have a history of car sickness in your past, we've published a lot of data showing that those patients are more likely to get concussed and have a vestibular problem following concussion. If you have a history of lazy...
Sorry, just to make sure I understand that.
Yep.
They're more likely to get concussed, or if they get concussed, they're more likely to have vestibular symptoms. Is it both?
Both.
Okay.
Correct. Less force will cause injury in those patients.
Wow.
Patients that have a history of migraine, less force causes injury and you're going to go down that migraine pathway. If you have a history of lazy eye or strabismus, you're going to go down the ocular pathway. And yes, less force causes injury. If you have a history of anxiety, you're going to go down that pathway more ubiquitously.
So you get an idea of how brain injury predisposes a person to existing weaknesses. And just on a bigger view, that this brain injury issue is not new. It's an unrecognized problem almost 20 years ago. And now they're starting to build some steam. Here's this last year from Megan Davison. She's the one that started the Step Up program, requiring police officers to have a behavioral health specialist with them. And here's her in this great study. She said brain injury can lead to impulsive decision-making, impaired decision-making, impulsivity, executive function deficits, such as risk assessment connected with consequential actions, which may increase risk of offending behaviors in violence as a victim and a perpetrator. And this is specifically true for women in the system. Excellent study that I'd suggest you read. And that's I'd like to turn to now my friend Jam Gajar, president of the Brain Trauma Foundation, who's been honored here to talk about something that really stuck in my mind about the predictive nature of our brain.
Things that people with concussions have that are common, and we call them subtypes, and we can measure them, and we also can correct them. And a lot of them have to do with attention. So when somebody gets a concussion, what happens is they have attention problems. They can't pay attention. They're risk for injury and risk for not only head injury, but other kinds of injuries, and can't perform. And so those attention metrics we took and funded by Department of Defense, we did large clinical trials using eye movements to look at how well we can measure attention. Now, eye movements are very particular because everything has to land on your fovea, the back of your eye. You put your thumb out, all you can see is your thumbnail, and that's all you can really process. Your brain can process. It can't process the whole world at once. So when it starts to move, your brain has to pay attention and predict where it's going to be. That prediction and attention can be measured very accurately, very quickly, and it's a measure of attention. And attention is really inhibitory control, which I know a lot of you are there at the conference for juveniles, individuals who are in the justice system, and a lot of those individuals have trouble with inhibitory control or paying attention, and may lead often to their circumstance.
I love that comment. Intention is inhibitory control. And this classic study in Stanford, the marshmallow test, where children would be asked to delay gratification. They get 2 marshmallows, they could wait for a minute or so. And how that's really part of the makeup. Those who couldn't wait throughout their life have a hard time controlling their behavior, their inhibitory behavior. So this is this idea of disruptive prediction. Concussion is a conceptual model in my mind that this loss of inhibition affects prosocial functionality. And so here's the model, the impaired spatiotemporal prediction model, that when we can't really predict how things are in space, in time, that causes anxiety, depression, irritability, cognitive, overstated cognitive demands, or in a more maybe a simplified way, poor inaccurate prediction of a current situation. That means anxiety. It's not relative to really what's going on. Negative prediction of future options, we could call that depression. Just some basic ideas of what we do and could do. We all know now there exists the blue assessment in professional sports to diagnose brain injury. And we see people that are diagnosed and they come back to play within a certain amount of time with good treatment. We need to apply our brain-based tools to individuals with behavioral disorders, including those in the justice system, for better outcomes in their game of life, so they can return to work, return to play. This time I'd like to just introduce a few organizational concepts as we're going to go through, and there's an acronym swoop, so I'm going to just do a little introduction. The NCCHC, this is a group I've been working with that establishes all the standards for the jails and prisons across the nation. Unfortunately, currently, that's really a don't ask, don't tell. If we could just get the standards that we know to be correct in the jail system, we would be so busy, it would be impossible for us to see all these individuals. BIAA, the Brain Injury Association of America, great group, really taking off more recently, just went to their main meeting in DC. They certify individuals, they work very closely with NASHA, the National Association of State Head Injury Administrators. This is what Russia does. She administers these state programs that we want to be a part of the table with, right? OBIS, this is a online brain injury survey. It's available to all of you. It's best practices. They've worked through all the bugs. You know, we have our own ways of self-reporting. I think we should really investigate these ways, and this will be out on our poster, but these are all free to you for what's called the CARE, the research as well as implications of screening. These screening tools are all available to you. We should at least be aware of them. I would suggest we consider using them and be a part of a team instead of being in our silo. And then this wonderful program that is free to you from MindSource, something called AHEAD, A-H-E-A-D.
Since every brain injury is unique, the effects can vary significantly from person to person. However, there are some common symptoms associated with brain injury, which can include short-term memory loss, delays in speed of processing, impulse control, poor judgment, and fatigue, to name a few. The focus of this session is to help each person understand how brain injury has impacted them individually, so everyone can learn how to compensate for the specific deficits they may be experiencing. It is helpful
this is something available to you all, hopefully,
to understand that
get into
many
that.
individuals.
One last one here. RNR. This is anybody in criminology. There was a time when there was a nothing works movement. That's why we warehouse so many people. The RNR is called the risk needs responsive principles. These are principles to match that's used to try to work and reduce recidivism. Important to understand when you talk to those in the justice system, RNR model. So my point is it's time to apply our treatment guidelines to this population. Let's move beyond just self-reporting and accommodations to directly proven interventions that we know about. And this is not alone. I had a chance to talk to Angela Colatonio, done some excellent work in Canada. Unfortunately, our whole TBI, NIH, and TBI is gone now. They was all doged out. But look what she asked. There's a lack of concrete recommendations to address this unique needs, and there's a dearth of reviews, and it's time to get the tailored guidelines to improve health outcomes. We want to be on the table for these guidelines as they are applied to our states. So here's a conclusion. Criminality is this costly, complex, multifactorial societal problem. Those who are incarcerated with TBI history should receive modified sentencing and treatment that directly address their injuries, behavioral and mental dysregulation. We now have the tools. We now have the tools for accurate diagnosis and effective treatment. Let's try to be part of that team. Got references outside, and key thing is that you can take a picture of this, join our group by at least becoming a subscribe to this channel, and we'll send you information and you can go in further depth. At this time, I'm just excited to introduce Dr. Zeisman, who's going to talk about her adventure in behavioral health, as well as the great things that she's intuited and applied in her practice. Dr. Zeisman.